Well, for those of you just joining, I do appreciate this opportunity that Dr. Taubman and the team has allowed me to present usually twice a year to this group, provide an update on the prescription monitoring program. I'm coming from you live here at Tumwater at the State Department of Health headquarters, and I'm happy to provide an update today. If you want to go ahead and go to the next slide. No disclosures for me as a public employee, and you can move on to the next slide. So this is just the general objectives I was hoping to portray today. I'm going to talk a little bit about what our data trends look like, and also talk more specifically about where we're at with trying to integrate the prescription monitoring program more seamlessly into electronic health record systems. So I wanted to give you an update on the overdose deaths. This has been the biggest driver of a lot of our work around this issue of trying to solve prescription drug misuse, abuse, and overdose. As you can see, we've had a very large rise in the prescription-related overdose deaths for a very long time. Finally, in 2009, we started having a steady decline in the number related to prescription opioids. Unfortunately, we've seen a counteractive increase in the number of deaths caused by heroin. Unfortunately, as you can imagine, as people find it more challenging or difficult to obtain controlled substance prescriptions for opioids, they've been moving to heroin, and unfortunately the Mexican cartels are very savvy business people, and they've been making more heroin cheaply available to try to catch people who may have be heading in that direction. That's something that the Department of Health and our unintentional poisoning work group has been trying to spend some time and some effort around. You'll may have noticed the bill passed as well this last session around naloxone, which can reverse an overdose event, and trying to make that more widely available. I think another key thing is, hopefully the state can move forward with making more treatment resources available to people who have substance use disorder regarding opioids. If you move to the next slide. So some people, may get concerned thinking, maybe we've cracked down too hard on the prescription drug side or have done too much. But I'd like to point out that, the federal survey that was done, I think, speaks volumes that, people who end up initiating on heroin typically start on prescription opioids first. And that makes sense. I think there's very few people who wake up and are not doing any drug abuse and say, wow, I'd really like to start injecting heroin into my arm today. That sounds like fun. Very few people do that. They have an acute injury of some kind, and through perhaps inappropriate prescribing, or just, because they don't know how to safely take these medications, they become addicted to the medications. And eventually, when prescription drugs are too hard to obtain or too costly to obtain, they end up, unfortunately, making that transition because of how powerful the substance use disorder is. And so the thing I like to point out about this slide is I hope the takeaway is, we need to do more on the prescription side to prevent people from turning to heroin. If we can prevent them from becoming addicted to prescription drugs, hopefully we'll see those numbers for heroin start decreasing also. Go ahead and go to the next slide. A big reason why I like presenting as many places as I can is we really feel like this is a problem area with the program. While we've had some good success and made some progress, currently less than half, only 31% of the prescribers with DEA numbers in our state are currently registered to use the program. And so that means basically about 70% of our prescribers aren't able to use the program to verify their controlled substance history of their patient, even though the program is free for them to register and use. So we're really hoping to get more healthcare providers interested in using the program and registered to use it, and hopefully actively using it. As a reminder, prescribers are allowed to set up delegate accounts for their nurses or medical assistants to access this information on their behalf, so they don't have to do all the querying or requesting themselves. If you want to go to the next slide. So I was really encouraged. I got to participate in the recent update to the Agency Medical Directors Group opioid dosing guideline that just came out in June of this year. I hope if you haven't taken a look at it, you will. There's a whole section on it just around when to appropriately use and engage the PMP as a resource when you're caring and treating for patients in the acute, subacute, or chronic stage. And here's just a few things I wanted to provide to you today, kind of some of the key practices we've been considering. So again, where's the prescription monitoring program really beneficial? It helps providers check for misuse, and they can also look for multiple prescribers and coordinate care. I think that's really important. You know, it's not always that a patient is trying to abuse drugs or commit fraud or diversion. A lot of times it's just, you know, they may forget to tell you that they had a dental procedure or something else done where they've obtained some opioid medications. And this is a way that you can see what other medications they may be on and be aware of other providers you may need to coordinate care with. You can also check for drug interactions or other harm. Almost all of the drug deaths are polydrug deaths, meaning the patient is taking, you know, prescription drugs with alcohol or prescription drugs with other prescription drugs. A lot of the deaths are opioids mixed with benzodiazepines or other tranquilizers and sedatives. It's also a great tool for using with compliance with treatment contracts. So if you have a patient under a treatment or pain agreement and they're only supposed to visit one pharmacy, one hospital, one provider for their care, you can make sure that they're staying on track. It also can just help providers feel better about prescribing to patients because they can know if their patient is staying on course or not. And the other side benefit we also allow is a prescriber can check all the prescriptions linked to his or her DEA number to just regularly make sure that there aren't any fraudulent prescriptions showing up that they didn't authorize or approve, or patients that they don't recognize. Go ahead and go to the next slide, please. So here's some things that we think can really help with integrating the prescription monitoring program into your practice. We really recommend using delegates to do your lookup to save staff time. Again, RNs, medical assistants, and other licensed healthcare providers working underneath a prescriber are allowed to access the system on their behalf. We think it might be a really great idea to train someone who's maybe tech savvy in your group to kind of be the PMP champion who can help people register and assist them if they have questions. We feel like you should definitely strive to have an account for all appropriate staff, both prescribers, pharmacists, and delegates. And we do like to point out that if you would like to, and it may be a good idea to, retain a copy of the report you pull from the prescription monitoring program into the patient's file or your electronic health record system. That way it can be part of the documentation for the treatment decisions you made. It might help describe and explain why you chose to prescribe or not prescribe to a patient or what kind of referrals you made. Next slide. So here's some times where we really feel like it's definitely a good time to check the prescription monitoring program. We understand how busy healthcare providers are and that every patient every time is likely not practical. Although I think in some care settings, providers in pain management or treatment type scenarios may check it more often. Definitely if it's a new patient, we would really recommend using the PMP. Also, if you do plan to prescribe a controlled substance, if the patient is in substance abuse treatment for some reason, chronic pain patients, again, for ensuring treatment compliance, and finally for evaluating episodic care. So that's at least 5 times where we're hoping people will really take advantage of the program and make sure that they take a look at the report. Next slide. Some things that you may want to consider doing after you've pulled a prescription monitoring program report on a patient, especially if you see at-risk or troubling behavior or records there, is definitely talk with the patient to determine the reasons for the risk behavior. And don't be afraid to follow up with the pharmacies. While our data is pretty good overall, data entry errors do occur, and sometimes there may be something on there that is not accurate. Definitely coordinate care with the other providers listed on the report. Again, consider using a patient agreement if that's appropriate. Verify that the prescriptions listed do match your records for the patient. And you can also look to referring your patient to treatment or other specialty care based on the discussions you have. And definitely educate your patients on the risks of opioid overdose. There's a great website put together by Dr. Caleb Bantagreen at the U, Stop Overdose that has a lot of great information there. Maybe one place you want to refer them to, or you might also want to take advantage of the Department of Health's Take as Directed website. If you go to doh.wa.gov and look up Take as Directed, we have a lot of good information there as well. Next slide. So for those of you who have been following us, we try to kind of track some general trends in the prescription monitoring program. So here you see the calendar year, the top drugs dispensed by generic name. Hydrocodone, acetaminophen, it has gone down quite a bit in prescribing by, about 225,000 prescriptions since 2012. That is still the #1 prescribed drug in our state. It makes up about a quarter or 1/4 of all the prescriptions we collect are for hydrocodone, acetaminophen. The rest of the medications there are kind of what you would expect, I think. We have Zolpidem, which is Ambien, a couple other variations of oxycodone, several benzodiazepines. We have a few ADHD medications. And the interesting wrinkle is the 2014 data, because Tramadol became scheduled on August 8th. And so we're very interested to see where that ends up, but it was already into the kind of the top grouping of controlled drugs as soon as we started reporting it, pretty much. And so it'll be interesting to see if that continues or not. You can go ahead and go to the next slide. So here we just wanted to show you what we're seeing in our data ourselves. This is patients who, during a calendar year quarter, saw 5 or more prescribers for controlled substances. And so you can see we've had a mostly downward trend of that at-risk behavior, and we're hoping that continues, where we've seen it drop off, and hopefully will continue to drop off as we track that over time. Next slide. This is a little different. We also worked with Caleb at the U, as well as Ryan Hansen from the School of Pharmacy, around trying to develop a more specific threshold for identifying patients at risk for overdose. And so our definition we've been looking at is patients at 120 or more for MED in a quarter, have more than 3 prescribers for controlled substances, and have opioids with overlapping benzos. Kind of pointing back to the fact that, a lot of these deaths are polydrug deaths. And this has been encouraging, too. There seems to be a good downward trend decline in the total number of recipients in our state who meet all 3 of those at-risk behaviors each quarter. So that's something we're looking at continuing over time to track. And we're also looking at whether or not it would make sense to identify those patients and actually send an email or an alert to the prescribers of those patients so they can make sure that they're aware that their patients are on more than 120, have seen more than 3 prescribers, and have opioid overlapping with benzos. So that's something that we're looking into as well. Next slide. I did want to point out, too, that we've been working on updating our regulations for the program to try to improve it. So we've held several stakeholder meetings already this year, and right now we're in our internal review process. Our goal is to hopefully have a public hearing in December if you're interested, and hopefully the rule publication will be in February or March of 2016. That's kind of the hope. To get these new rules in place. If you go to the next slide, I'll start walking you through some of the things we're looking at changing. The big one we're trying to do is right now we collect our data weekly. And while that is fairly good, we'd like to see if we can improve how current the data is. So we're looking to move and have pharmacies report daily. Now, that wouldn't apply to veterinarians because they have the legislature has a different statute in place for them regarding how frequent they must report. But for the main pharmacies and other prescribers who treat human patients, the idea is to have them start reporting daily. We've also tried to clarify zero reporting, which is when a pharmacy has nothing to report during the reporting period. We've also been looking at trying to get better patient identification to ensure we can match patient records better across pharmacy systems. That's always been a very big challenge when a patient, for example, could be entered as, Chris Baumgartner at Costco, CJ Baumgartner at Rite Aid, and just Chris Baumgartner at Walmart, trying to make sure that we have some more consistent ways to ensure that we're getting all the records together for each individual. We've also been looking at adding some additional data fields that we're hoping might help the system. Some of those examples include adding the pharmacy's phone number and prescribers' phone numbers, so that rather than just an address on the report, you maybe have a contact number for those prescribers and pharmacies available on the report. We've also been looking at adding a species code to better help us keep the data clean on our end to separate the prescriptions for humans versus animals. And we've also been looking at collecting NPI number with the idea of hopefully being able to do some more public health surveillance and research around prescribing by different specialty types, because right now we only get DEA number, and so we don't have a way to break out prescriptions by different types of prescribers. Next slide, please. We're also looking to clarify parental and guardian access, because right now our rules has some confusing language there. Currently, our rules do not allow a pharmacist to delegate access to a technician, just like a prescriber can delegate to a nurse or a medical assistant. So that's something we're looking to add for pharmacists to hopefully make their access and use of the program more efficient. And we've also been trying to clarify that you can store this data in a patient medical record. And so that's something we're looking to do through our rulemaking process as well, just because we seem to get questions and confusion on that topic. Next slide. I did want to give you an update, too, on where we're at with our connection to One Health port. The whole goal here with connecting to our state health information exchange is to allow healthcare providers to start accessing PMP data in the electronic health record systems they already use, rather than having to log into our web portal separately. This connection is live and is currently being used by 71 emergency departments in our state through the Emergency Department Information Exchange, so they actually do get PMP data seamlessly through that connection, and so we're excited about that, and we're hoping to expand that to other care settings. The news I'm excited to share today, you can knock on wood and cross your fingers for us, is it looks like we've finished our pilot testing with Epic, which is probably the largest vendor for electronic health records in our state. And our hope is that Epic will be looking at pushing out an update to their clients in Washington, which will hopefully allow Epic clients to use the medication reconciliation module to request this information inside of Epic, rather than logging into our system separately. So hopefully there will be more to come on that soon. And we're hoping other health system vendors, Cerner, Meditech, NextGen, will hopefully follow suit. Next slide, please. I did want to mention, too, that we do have the prescription monitoring program approved as another specialized registry for stage 2 meaningful use compliance. We're excited about that. We're hoping it'll add an additional business incentive for health systems to make this type of connection from their electronic health record system. As a public health agency, we are allowed to do that, and so you can find out more information about that on our website, which is just doh.wa.gov/healthit. It's right there on the slide. And if any group has questions or is interested in exploring that further, let me know. Next slide. We've also been working on an additional public health surveillance project, which we're pretty excited about. We got some grant money to integrate PMP data with other data sets like death data, treatment data, hospitalizations, to do a mapping project. And the idea is to try to look at, for example, areas where there's a high need for medication-assisted treatment based on a lot of at-risk behavior seen by recipients in a county, for example, but there's very low PMP use by providers or very low treatment availability. Those might be areas we could direct more resources to and more education and outreach. So that's kind of one of the big goals. We're also trying to look at, what kind of treatment availability through opioid treatment programs, as well as buprenorphine providers, where are the gaps in our state? Because that, is a big concern we have, is making sure there's enough treatment resources available for opioid substance use disorder. So if you go to the next slide, this is just a draft map, so you can kind of see what we've been working on with our partners in this project. This would be how far people have to travel to get even to a buprenorphine provider. And so that's something we've been looking at as one of our potential maps to help state and local level policymakers look at, kind of the needs and demands of this epidemic. Next slide, please. That is our program staff now, so you can get a hold of us. We have an epidemiologist on board who's doing a lot of our surveillance work, which is exciting. Gary and Matt are available to help your organization if you're trying to get registered for the program or want any type of education or training. And I'm still around and available too if you need to get a hold of me.